Good morning, everybody, and welcome to our first Psychiatry Grand Rounds for 2018. Today we have the pleasure of having Dr. Yvette Sheline with us. Dr. Sheline is the director of the Center for Neuromodulation in Depression and Stress and McClure Professor of Psychiatry, Radiology, and Neurology at the University of Pennsylvania, where she also directs a T32 postdoctoral fellowship program. She received her bachelor's in biology from Harvard, a master's in physiology from Yale, her MD from BU, and completed her psychiatry residency at Harvard's Beth Israel Hospital. She held faculty appointments at Stanford and WashU St. Louis before joining Penn in 2013. Dr. Sheline conducted pioneering work on hippocampal volume loss in major depression, as well as the moderating effects of antidepressants. Her research integrates structural and functional neuroimaging and neuropsychological measures to understand how depression and stress change the brain and how these changes are impacted by therapeutic interventions. She also has described antidepressant effects on amyloid formation, which may have important implications for Alzheimer's therapeutics. Dr. Sheline is boarded in both adult and geriatric psychiatry. Her CV lists over 110 peer-reviewed data papers and scholarly reviews. Her honors include a NARSAD Young Investigator Award, 2 NARSAD Independent Investigator Awards, an NIMH Clinical Mental Health Academic Award in Geriatric Psychiatry, 2 NIH Mid-Career Investigator Awards in Clinical Research, and a NARSAD Klerman Award Honorable Mention. She served on the board of directors for the Advanced Research Institute, American Association for Geriatric Psychiatry, and the Scientific Council for the BBRF, and she is an ACNP Fellow. Her talk today is entitled Resting State Network and Task-Based fMRI Changes Predict Transdiagnostic Symptom Improvement Following CBT in Major Depression and PTSD. Please join me in a warm welcome for our Grand Round speaker, Dr. Yvette Sheline.
Well, thank you for that very nice introduction, and thank you also for arranging for me to come here, and for all of you who've been so wonderful to meet with and talk about your work and my work and kind of where the field is going. I see that I'm in the correct building to be giving this talk. I noticed the name of the building on my way in. Let's see here if I've got the right one. And what I'm going to be talking to you today about is sort of several different ways of slicing and dicing data. I'm thinking about this as an implementation of the research domain criteria, which has pioneered the concept that we all already knew, that really depression is seen across lots of different disorders. It's not just seen in major depression. And so that dimensionality should be able to be correlated with other things about depression in various disorders that go along with depression, including brain circuitry, but also genes, molecules, all the different things that make up why somebody would have depression in the first place. And, you know, in terms of understanding specific neural circuits, we really haven't been able to parse those out very well because they're seen across so many disorders, and so we're going to have to use new tools in order to understand how that works. The other thing is that in trying to understand how brain circuits might be implicated, most studies, and I'm very guilty of this too, have used their own favorite a priori seed regions or brain regions and looked kind of like looking under the lamppost. You know, why do you look there? Well, because you have some ideas about what that region might do, or it's your favorite region, or something else. So I think starting to go at this from a more principled approach is where the field needs to go in order to understand these things in a more fundamental way. So, oh yeah, and most studies also focus on just one diagnostic category. So why look at depression and PTSD? They're both chronic enduring conditions with lots of morbidity and mortality. They have high rates of recurrence. They have very high co-occurrence with depression occurring in the majority, actually, of PTSD cases. And even when you treat PTSD, there oftentimes are residual symptoms. So needing to understand what those are and why. And as studies have looked more frequently at childhood and started to collect the data, there is actually quite a fair amount of trauma that goes unrecognized in major depression and may explain some of the findings that we see. And even when you remove the overlapping symptoms, the high rates of comorbidity are still seen. Another thing that I think, especially here, people would appreciate in this audience is that the cognitive problems are especially linked to illness chronicity, both in PTSD and may be difficult to treat in major depression. So, I mean, I think we're understanding more about how the cognitive impact is more severe than had been thought initially. So, what can we do to probe across disorders? Are there brain disorders that you could see in resting state studies that would give you some idea about the commonalities and differences? And are there brain signatures of depression or anxiety that you could see across disorders? Are there dysfunctions of specific circuits that are common to major depression and PTSD? And the thing I was actually especially interested in is when you used a therapy, in this case cognitive behavioral therapy, were the deficits corrected in the same way? You know, or you know, you could certainly imagine that they would be corrected in different ways in different disorders. So looking at this first at baseline to see what was similar or different about the subjects who had PTSD and depression. It's kind of a vanilla study in the sense that we did all the usual things. We did the SCID and CAPS, the clinician, what's it called? The clinical assessment for PTSD symptoms in PTSD to make the diagnosis of PTSD, and then, of course, the structured clinical interview to be sure that we had real depression and real PTSD. And we excluded neurological disorders. And I'll say here, especially, again, in this audience, I think it's worth noting that we ruled out anybody who had had a loss of consciousness with trauma. So we didn't rule out people who'd had a concussion, you know, some kind of symptoms, but if they had actually lost consciousness, they were excluded as having had a neurological disorder, which, you know, again, could influence the kinds of results that we get. And we assessed depression and anxiety on the same day as the imaging. And then we had a requirement that everybody completed all the measures. And we also had pretty stringent motion correction exclusion criteria because those have been shown in a lot of studies to have a major impact on what findings you get with especially with resting state studies. This is the characteristics of the sample. I'm going to start by describing the baseline characteristics and then tell you about the longitudinal sample. You'll notice that there's way fewer people in the longitudinal sample, and that's because a lot of people chose not to get treated. These were fairly low SES people, and to commit to 12 weeks of cognitive behavioral therapy is a big commitment when it's hard to get in and get that treatment. So we had quite a large group of people at baseline, 104, and only 50 at 12 weeks. And you can see there oops, I'm not very good at this. Let's see here. The depression score is quite a bit higher, of course, in the depression patients, but certainly non-trivial in PTSD. And the anxiety, the anxious arousal is fairly similar in the PTSD and depressed folks, actually slightly higher in depression. And then this is their performance on a task that I'll show you in a bit, how that changed with treatment. So, and again, these are pretty standard kinds of parameters for getting imaging. A high resolution, effective resolution of 1 millimeter, 2 collections of resting state data totaling a total of about 16 minutes, which in this day and age is kind of the minimum that people would accept as being sufficient, because the amount that people want keeps going up and up and up, especially now with the connectome sequences. And these were, we used kind of the usual smoothing, confound regression for motion and for global white matter signal, bandpass filtered and co-registered. And then I'm going to show you this in pictures so you can see it a little better, but we did something called multivariate-based, distance-based matrix regression, which is a really cool technique that allows you to covary and to test multiple variables at the same time. So you can get a good sense of how several different variables affect your results. So we were able to regress out the effects of group age and anxiety to look just at a voxel-wise significance map. And then we did post hoc seed analysis, and I'll show you why, using the amygdala, because, just spoiler alert, because it turned out that the amygdala was the region that was identified as the most different across depression, PTSD versus controls. And so because you get a fairly non-distinct result when you do this MDMR whole brain look, you can't see as well as you could if you segment out the region you're interested in and then look at the connectivity of the region. So here it is in a cartoon. So this is, we used the advanced normalization tools, which won a contest for being the program that gave you the best results doing these kinds of normalization. And I don't know exactly how they decided that, because I wouldn't know what the actual gold standard would be, but they did decide that this was the best tool. So if you want to look for a new neuroimaging tool to do your registration and normalization, this would be a good one. And also it was invented at Penn, so of course we're partial to it. But basically, to get a better registration, we created a specific population template from our participants, and then each T1 image was registered to that template. And then using the resting state data, every voxel was correlated with every other voxel, giving a connectivity map. And then this statistical method, the MDMR, was used to calculate a distance metric between each of these pairs of connectivity maps. And at the same time, it included the covariates of anxiety, age, and motion, so that you were looking at the effect of depression, but covarying for the things that you didn't want to have included in the model. And then, so all this can do is tell you where is the region or set of regions that are the most different in patients and controls. Where are those voxels located? But it doesn't tell you if those voxels have abnormal connectivity, what is the abnormal connectivity with? It just tells you those are the ones that have the abnormal connectivity. And sure enough, it turned out to land pretty nicely in the amygdala. But since, as you can see here, it's kind of splotchy, then what we did was something called a multi-atlas label fusion segmentation. So each person's amygdala, person by person by person, and this took literally a month to do of intensive computer time, because it's a very intensive technique, was segmented out. And then once the amygdala was segmented, then the connectivity of the more specific amygdala region was then correlated again with the rest of the brain to see what the connectivity of the amygdala was in the patients versus controls. So this shows you here, these are the regions. It's kind of blocky because it's fMRI data, but landing in the amygdala. And then because it did, we did this mouth segmentation. You can see in green a nice, pretty amygdala with this splotchy thing on top of it. But then using each person's own amygdala segmentation, we then correlated the connectivity of the amygdala to the rest of the brain. And what we got was a bunch of regions in dorsolateral prefrontal cortex, some caudate, some frontal gyrus, cingulate, insula, but mostly, I mean, you can see here the maximally different regions were in dorsolateral prefrontal cortex. And then when we correlated the connectivity of the DLPFC regions with amygdala, the decreased connectivity that was seen in patients correlated with the severity of the depressive symptoms. We also looked at anxiety, and what we found there was that the more anxious you were, the higher the connectivity was with ventromedial prefrontal cortex. So it went the opposite direction, that you had a higher connectivity with, and it's sort of, you can't see it very well here, but it does kind of extend down into subgenual cingulate as well. So the baseline data showed us a double dissociation in amygdala connectivity with depression severity associated with amygdalo-frontal hypoconnectivity, and anxiety severity associated with elevated connectivity between amygdala and ventromedial prefrontal cortex. So it seems to be a neurobiological feature across these disorders, across the clinical diagnostic categories, and supports the negative valence construct of that this aspect of both PTSD and depression is explained in brain circuitry terms. So then looking across disorders, can we understand treatment response? What does, in this case, CBT do across major depression and PTSD? And of course, when you use so-called CBT in PTSD, you're really doing cognitive processing therapy. It's a related but distinct therapy, which I got a ton of hassle from the reviewers, because they said, how can you talk about CBT when in PTSD it's really cognitive processing therapy? And we said, mea culpa, you're so right. see our supplemental section on the differences between CBT and CPT, but really they use the same kinds of techniques to help people stop generalizing so much about what a rotten person they are, and how everything is in life is terrible, etc., and to have more realistic strategies, and so they accepted our argument that that was common, even though there was an exposure component to the cognitive processing therapy. So we did resting state analyses, which I'll show you first, and then we also looked at an emotional task. That would be great. Thank you. I'm just getting over a cold, and it's getting to my voice. So we had 51 unmedicated right-handed participants. There were 34 with PTSD and 17 with major depression. And they got 12 sessions of manualized CBT from a very good neuropsychologist who was specially trained in CBT and CPT. And everybody got MRI scans on the same scanner, the Siemens 3T Trio, before and after treatment. And the controls were also scanned twice. And while they were getting scanned, they did both resting state scans, or received resting state scans and task-based fMRI. So this map is from YO. It's one of those standard parcellations of the brain into component networks. And I think it's used in, I don't know, a gazillion studies to look at what role networks have. And then I was fortunate to team up with a statistician who had just developed this method for doing longitudinal principal components analysis. So, I mean, we all know what principal components analysis is, right? It's a way of decomposing things into a sort of principled look at what the component is in a specific thing. It could be anything from, you know, brain networks to genetics to whatever. But what she was able to do was to derive a way of doing this longitudinally for these resting state networks. And another important caveat is we restricted it to the fronto-parietal network because we didn't really have enough data to be looking at all the networks without correcting ourselves out of business. So, given that we had seen this difference in the baseline data with the fronto-parietal area, we decided we would just look at the fronto-parietal network and see what we got in terms of change over time. And so this LFPCA identified 4 principal components that contributed significantly to the longitudinal change in connectivity. And so how do we know 4? Well, this is probably more technical than most of you want to know, but you can create a scree plot, and the point of inflection tells you, like, aha, it's 4, not 10, not 5. And of these 4 components, it was the second one that differentiated the CBT-treated patients from controls in having a significantly increased connectivity to the amygdala with the fronto-parietal network after they had gotten CBT. So this just, again, this is a cartoon where you have a difference map of the patients and the controls, and then you do the longitudinal principal components analysis. It yields these 4 significant components. So each person gets a principal score when you do this analysis. And then plotting those out, you can see even here that it's going to be principal component 2 that was significant. And then mapping that onto the brain. So this is the YO fronto-parietal network in blue that the differences were being mapped onto. And these areas in red are the principal component 2 regions, showing controls and the change in controls. So they didn't change because they didn't get any CBT. Another interesting thing would be, well, what happens if you do CBT in controls who probably don't really need it for depression, but it'll be interesting to see if you just have them practice some things, if it would change their brain. But we didn't do that experiment. And then here's the patients who changed in improving the connectivity with this fronto-parietal area. And then, again, this is in response to reviewers. The reviewers said, well, okay, that's all well and good, but what happens if you do a voxel-wise analysis, a whole brain voxel-wise analysis? And so we said, okay, we'll do it. And so you can see here in green, which is actually pretty amazing given how few patients we had that we actually got doing a whole brain voxel-wise analysis, got the same area to be clearly different from between patients and controls in the improvement in connectivity. And so you can see here are the patients at baseline and the controls, and here's after 12 weeks of CBT. And then just breaking it down by PTSD and depression. So here are the depressed folks in the blue, and the PTSD in green, showing the connectivity at baseline and then following CBT. So we also did a conflict task at the same time that they got resting state analysis. And this is a task we've published on before. It's essentially an emotional flanker task. It's a very rapid task where people are, they have the simple task of just saying same or different, same or different. But that's, I mean, we're not really interested in whether it's the same or different. We're interested in seeing how their brain reacts to these different emotional faces. I'll show you that in a second. And then we did a mixed effect model controlling for age, motion, and education to look at the effects of depression on brain circuits in a whole brain voxel-wise analysis. And we did separate models also where we controlled for anxiety so that we could look more specifically at depression. And then we also did a model where we looked for the effects of anxiety on brain circuitry so that we could look separately for those two effects. And then control for depression in the models for anxiety. And we ran a linear mixed effect model to look at what is this? Oh, so yeah, important to say. We also looked in controls to see if they had an effect of just passage of time, and they had no change in the paired t-test. And then we used the controls as a reference region to show time and practice voxel-wise analysis, correcting for multiple comparisons. And I don't know how familiar you guys are with this, but currently in the imaging literature, there have been studies showing that most of the thresholds for finding significant effects were actually identifying effects that turned out later to perhaps not be significant. And so now the threshold has been moved up to a Z of 3 or above, 3.09 or above, as being a sort of safer level at which you're not going to see your results retracted later or not replicated later. So, so we used a fairly stringent threshold as well in order to look for these effects. We also looked at the people who did complete the treatment and those who didn't. Either they dropped out or they didn't enter treatment, and found that there were no effects, no differences between the people who completed treatment and didn't. So this is the task. It's you look either in the vertical axis or the horizontal axis, and that's indicated by a light bar before you start that run. And then it's actually hard to do. It's really fast. So you're just pushing the button. If you were looking here, you'd say same, and here you'd say different. Then, you know, we were, of course, getting the brain signal. You can see that the patients and controls didn't differ in accuracy or latency. And then these are the regions that are implicated just across the board in task condition. You can see it's some cingulate, some dorsolateral prefrontal cortex, some limbic regions, and some visual regions, of course. And this just shows the cross-sectional sample in terms of what different kinds of symptoms they had. You can see that for the anxious arousal part of MASQ, they're pretty similar here. There's a whole range. And for depression symptoms, they're similar, but there's a missing part here, which is, of course, because if their MADRS was less than 18, we didn't include them in the study. So it would be interesting to have included a subsyndromal group as well, but we didn't. And then this is looking at the cross-sectional sample and the longitudinal sample, showing, actually I think I already showed you this, but showing that the education is similar, age is similar, almost all females. And another thing I should say, so the PTSD sample are all intimate partner violence survivors. So this is not all veterans and intimate partner violence survivors. It's only female intimate partner violence survivors because that's who's in the study. And Nobody was on psychotropics. And we already looked at the performance data. So this is kind of interesting, I think. So it showed that looking at depression across patients, if you looked at the amount of hypoactivity versus MADRS, those were correlated here. You can see there's a MADRS score. And then this is when you regress out anxiety, control it for the MASQ-AA, you get essentially the same relationship here. And then this is looking at the effect of anxiety, just entering in the MASQ-AA score, and you get this nice relationship. But then if you control for the MADRS score, there's no longer any surviving effect. And then here is just, again, plotting plotting them by PTSD and MDD and controls. You can see the controls down here in the basement, and these are similar shapes with MDD having a higher MADRS score, basically, but the same overall shape. And then looking at those patients with PTSD who had higher levels of depression. So anybody who had a MADRS score of 18 or above, if we removed those people from the analysis and just said, okay, let's look at the PTSD people who are left in the analysis after we take out the ones with high depression, there was still a correlation with depression severity even after we removed. So here's the depression, here's the PTSD and controls. And then, like I said, we looked at the people who completed the study and had 2 usable scans, and then compared it with those who either didn't enter treatment or didn't complete treatment, or didn't return. So one of our, you can see the perils of doing this kind of work. You start with 34 people who enter treatment, and then, actually this is not bad for this sample. A lot completed, a lot didn't return for being rescanned, and then unfortunately seem to have a fair number who moved too much. So you end up with this kind of a yield from a study that starts out with a lot more. I don't know why I keep putting in the same slide over and over again. Sorry about that. This was something that was, to me, a little unexpected, because usually we don't see much in the way of change in task performance. But we did actually see a significant improvement in the patients following treatment with CBT. They got faster in being able to do the task, and it correlated with how much better they got in terms of their depression symptoms. And then this is the change in patients, showing which regions were involved. And you can see it's some dorsolateral prefrontal cortex, a lot of inferior frontal gyrus, a lot of cingulate. Here it is specifically with the volume of regions involved and all the different regions that were involved. So a fair amount of cognitive control cortex, cingulate, and then some occipital cortex, of course. And here, plotting out the different regions again, too many to really take in and think about, but basically it just shows that they did change significantly, whereas the controls did not change. And I think that's the more important thing, is that we got this change in the patients that we didn't see in controls. We did see some change in controls, but they were different regions. So these are all the regions in controls that changed over time. A lot of parietal cortex and some occipital cortex, mainly. So I think the important thing is that CBT did treat both depression and PTSD, that the changes that we're seeing in the middle and inferior frontal cortex and the connectivity between the amygdala and the fronto-parietal network are similar across the disorders, with the caveat that I said before. You know, this is a limited sample of PTSD. I don't know what would be seen if we were looking at veterans with trauma and TBI, and you know whether those same things would be seen. But at least in this sample, we did see that. The longitudinal principal components analysis suggests the importance of the change in amygdala connectivity. That by improving the amygdala connectivity, we saw a change in depression with CBT across the disorders. And the task analysis suggests that particularly DLPFC improvements from baseline are related to depression symptom severity, and then when people have CBT, it corrects the cognitive controlled network deficits. And it suggests that across these disorders, we're able to see a common dimension of depression. And I was surprised, actually, that we didn't see a similar effect with anxiety, because I would have thought anxiety would be equally important. And just quickly to remind you, I'm sure you know this, but prefrontal cortex has the effect of exerting moment-by-moment control over regions. That's been known for quite some time. And some elegant experiments dissociated those into more of a monitoring function and an implementation function. So if you have a monitoring function, you can bias other brain regions to implement more control so that you get more appropriate goal-directed responding. And actually, attention, concentration, and executive function are all implicated in PFC. And CBT may work by strengthening these connections within these brain regions. So the implication to me would be that, you know, practice makes perfect. If you need to have more connection in these regions, perhaps by having more practice, you would get a better effect over time. And I think there's some suggestion in the literature that people who have worked harder in doing their CBT have a better outcome, but we're actually going to be testing that directly in our next CBT treatment trial, where we're going to be using a much smaller amount of therapist time and a lot of home computer practice doing these kinds of CBT implementations, and then also handheld devices. And since we'll have spyware on the computers, we'll be able to see how much time people actually spend doing their homework, and we'll also be able to look at how much time they, you know, why are you laughing? We'll be able to, you know, see how much time they spent in interacting with their handheld devices. So I already said this. So because what we found was really more of a DLPFC effect, it implicates, and I wouldn't want to say this too strongly because I think it's all in there, but what we found would be more the implementation deficits being involved in this particular implementation. So I'm going to switch now to something else that's brand new, and it's using a network analysis from kind of the more graph theory-based network analysis models, and these are all the same patients. So essentially, this is different ways of looking at the same data. So that by doing a network analysis, you can actually look at multiple different effects and what the interaction across networks is over time and how that changes. So we did both a univariate analysis, network by network, and then we threw them all in there, threw them all into the mix. And again, fortunately, I have very good statistical colleagues who taught me how to do this penalization technique. So it has two different penalties that force the data to be more sparse. One is called a lasso technique, and the other is a ridge penalty. And sometimes those are called tuning parameters, but in a data-driven way where you don't say what sparsity you want. You just let the data decide how sparse it needs to be to give you the best outcome. It then forces the least significant components of the data to zero. And so you're left with those more significant components being the ones that drive the analysis. So we used, this is, again, all of the usual power nodes, 264. But after excluding those for which there wasn't good coverage or where there were too few nodes per network, et cetera, we ended up with 220 nodes. And then we did a wavelet coherence analysis. And why did we do that instead of a Pearson's correlation? Basically because it's less affected by outliers. And so it gives a more stable result than if you do Pearson's correlation. And then this is, again, from graph theory. You look at the within and between network connectivity. And so you end up in a 2D plane with 4 different quadrants. Those brain regions that are, well, let's start with the easiest, a cohesive connector. It's connected to itself, and it's connected well to every other brain region. A cohesive provincial, it's connected to itself, but it's provincial. It doesn't connect well with other things. An incohesive provincial, it's not connected too well to itself, and it doesn't connect to the rest of the world. Or an incohesive connector, it's connected outwards, but not inwards. And then using that analysis, we mapped the different brain networks onto these quadrants. So some of the easiest ones to understand are the somatomotor network. It's a provincial, but that is so it's not connected to other networks, but it's well connected to itself, or visual system, same thing. So regions that have gotten increasingly segregated, there actually are interesting neurodevelopmental studies now looking at how these networks change over time. And if you look from childhood into adulthood, what you see is increasing segregation of lots of networks so that they become more and more specialized, for instance, visual system. And then default mode network is kind of, it's a classic case of something that is both, it connects to itself and it connects widely to other regions, which makes sense since it's a brain hub. And then I'll point your attention here to the ventral attention network, which is a non-cohesive and incohesive provincial over here in this quadrant. And when we then looked both in the univariate analyses and the multivariate analyses, what we found was that here's this big change in the direction, the ventral attention network, in the direction of becoming even more of a provincial and even more incohesive. So, and that was the only network that survived correction for multiple comparisons. So it's kind of an odd result in a certain sense. And here again is using the multivariate look where you put in the between and within connectivity of each of these different predictors, and then using the penalization techniques, like I was telling you about, it still arrived with one significant predictor, which was the between network connectivity of the ventral attention network. So what does that mean? Let me go back here to another point in this thinking, and this is still, I'm just starting to think about this, but there is some suggestion in the engineering world about brain controllability analysis. And so you have regions that can get you a short distance in terms of implementing brain control from a low energy state to a high energy state. And those are things such as the fronto-parietal network, where it requires a large amount of energy to move the brain to a fairly different state. Or lots of networks where their function is more to change a little bit, but at lots of different juncture points. And then there are regions such as the ventral and dorsal attention networks that are on the boundary of network communities. And their role is to either facilitate integration or facilitate segregation of cognitive systems. And so that the ventral attention network falls right on that boundary. And so their role would be to either bring networks together or segregate them. If you think about, an attention system, and you've got depression, it seems to be perhaps, and this is very speculative, but perhaps that if you can not, you can segregate more and not be so connected in, for instance, with your limbic system and with your salience network of things that seem salient to you, that you can segregate more and be, so it's a compensatory mechanism of being even more segregated. Perhaps that may be something that could explain what the role is here. That's about the only way I can explain it. So in the future, what we're hoping to do is to look at an in-depth probe of time courses. So is there a correlation between the amount of time spent doing CBT and how well people get? I mean, if that's true, could we make CBT more accessible, because there's so many parts of the country where there aren't enough therapists? Can we use RDoC criteria to identify brain circuits across an even broader set of disorders? And so I have a Human Connectome grant now that will let us do that. It's called the, what did I name it? The Functional Connectivity of Anxious Misery. And so it includes all of the different negative valence disorders, and we'll be characterizing people with lots and lots of different neuropsychological measures, symptom measures, startle, lots of brain imaging, and then we're actually going to have them have actigraphy for a period of time so we can collect actual physical data on them as well. And then I think it would be interesting to be able to look at disorders that we think of as being really separate from depression, but that may actually have depression as part and parcel of the actual disorder. So my neurology colleagues tell me that when you treat epilepsy patients, you inevitably are treating their depression as well. I mean, it's just kind of part of the disorder. Diabetes, we think of it as having depression, but when you think about the insulin receptors and how the brain may actually be different in something like diabetes, it's not too surprising that there are high rates of depression. Now that we're learning more about all the different leptins, ghrelins, and all the other gut hormones, again, there may be things that are sort of inherently part of those disorders that overlap with depression. And certainly pain, pain syndromes such as fibromyalgia or other pain syndromes. And then I think it would be really important to understand what are the commonalities and differences across treatments. So antidepressants, CBT, but also vagus nerve stimulation, ECT, TMS, which we're starting to do a fair amount more of. And then deep brain stimulation, although Penn has given up doing that except for Parkinson's disease. And then obviously, ultimately, the goal would be if we can understand these mechanisms better and we can understand as somebody comes in to see us how their symptoms line up and what their brain networks look like and what the different treatments do differentially and in common, maybe we would be able to have a better shot at individualizing treatment. So with that, I'll stop and I'll acknowledge my Penn collaborators and some of the people at WashU who helped me gather the data that I presented today. And of course, my funding source, the NIMH.
Yvette, thank you very much for giving us really a lot to think about. I'll make one content and one process comment. So for the trainees here, this may be sort of obvious to think that the way psychotherapy works is by changing the brain. I'll just say that in the span of my short career in psychiatry, that's a revolutionary concept. And so I think from a content standpoint, it's remarkable to see people actually demonstrating, if not yet a causal link, at least a strong connection between the gains made in psychotherapy and in severely ill patients and changes in the brain that where you can see connectivity shifts from either pole of the brain. It's really remarkable to be able to see that and really a dramatic shift in the way psychiatry has approached sort of thinking about the way the brain works and the way psychotherapy works. From a process standpoint, you pointed out several times the importance of sort of the team approach and really smart statisticians and people who understand how to process huge amounts of information and to put it into a coherent framework via different analytic strategies. And I think that's another shift in sort of paradigms in the way we have gone about understanding the brain in psychiatry, bringing to bear sort of a team approach where people whose expertise you may not have thought of as being sort of relevant to things like CBT, and yet unless we figure out smart ways to process all the information coming out of the brain here, that we lose a lot. So those are the two most immediate things that come to my mind, but I'd like to open up the discussion now to questions from the audience, if that's okay.
Great work, Yvette. I really enjoyed that. Couple of questions. One, in terms of your last point, which is about individualized treatment, have you done any analyses of the change data looking to see whether there are baseline features of either resting state connectivity or task-based response that predict who had a clinically significant response to the CBT?
So I don't think we have anywhere close to enough data to be able to do that. But yeah, when we have the Connectome study, which will have 250 people, we'll have more of an ability to do that, although that's only an observational study, it's not a treatment study. So yeah, I think it points to needing to have data centers that collaborate and pool their data so that you can look at that.
Right. And then the second question was just to see whether you had explicitly tested, because I really like your cross disorders approach and the evidence that the depression is really the level of depression is what's correlated with these brain features is very convincing. But I wonder if you've taken the step of actually comparing the effect sizes for depression to the effect sizes for group, which is what people would have normally done, is sort of say, okay, well, what's the difference in the brain between the people with PTSD and with depression? Or have you looked at all at those group differences? Are they striking? Are they different than what you see in terms of what's the same between the groups?
So we have looked at that, and when we compare them, we see, the problem you get into then is you start to see lots and lots of different brain regions that are slightly different. And so when you correct for all of that, you get nothing. And so I think again, you're just hobbled by the sample size of the data.
But within the regions, like for example, taking the resting state, the connectivity between amygdala and DLPFC.
Oh yeah.
Is there, is there a group effect there too, or is it just that's basically only driven by your depression severity, and there's no difference between the two, between PTSD and MDD in the degree of that connectivity?
So the degree of connectivity wasn't different between PTSD and MDD.
I was wondering if you're able to tease out any hormonal effects, phase of the menstrual cycle, these oral contraceptives, and whether sleep might be a mediating variable, the people who were dropped out versus continued, perhaps sleep improved. And I'd also be curious to know if there's any overlap between what your findings are in the rapid-acting antidepressant treatment like ketamine or sleep deprivation that occurs right away.
Mm-hmm. So, well, in this sample, we don't have data on menstrual cycle phase, so we can't look at that. And let's see, what was your second question? Sleep, yeah. Well, certainly PTSD has a huge effect on sleep, and so does depression. And so, I mean, I think the answer is yes, sleep is important, but I'm not sure. I mean, I don't have data on who were sleeping how much, other than what their score was on the MADRS, which asks about sleep. So I wouldn't have any specific information about, like, this person slept 3 hours and that person slept 8 hours.
That might just, CBT might help them sleep, and that's when the brain changes.
Mm-hmm. Mm-hmm. It could be, sure.
And then the interaction with the pathways for more rapid acting.
So I haven't done any of those studies, but that would be something I'd love to take a look at, would be how do ketamine or rapid-acting antidepressants change brain circuits? Is it the same circuits that are changed in CBT or in SSRIs?
Thanks, Yvette. That's terrific. I'm going to ask you to flip your perspective 180 degrees. Suppose you were developing a new CBT or a new intervention.
Mm-hmm.
If you were following the requirements from NIH these days, you would have to address things like target identification, target engagement, mechanism of action. How would you approach those issues if you were developing a new treatment? Yeah, and you couldn't look at mood improvement.
Well, you'd want to look at mood improvement as well, wouldn't you? I mean, yeah.
Makes it a clinical effort.
Okay. So let's say, I mean, are you thinking like pill X or intervention X, where maybe it's some different set of exercises you have them do?
Identify
Mm-hmm.
region, circuit, set of circuits. Let's suppose those are real
Mm-hmm.
and well validated and replicated and all that kind of stuff. If you know that, how would you use that information in the development following the NIH?
Well, so we are doing that right now with our kind of computer augmented CBT. Our hypothesis is that it will change the brain in the same way. So essentially it's a non-inferiority study where we propose that computer augmented CBT will have the same effect, and that we'll be able to get the same effect in these same regions. So we'll look in those same regions. If I were thinking about a different treatment, such as, I mean, for instance, let's say ECT hadn't been invented, and I wanted to see what was the effect of ECT, I think you would just have to start from the ground up, and you'd look at where ECT worked, what circuits it worked on, and then in terms of demonstrating that to the NIH, you would have to look at were those brain regions implicated in the effect of ECT? I don't. Mm-hmm. So.
A question about, well, two questions. One is about the education. I think you said the groups weren't different, but to me the controls looked like they had a lot higher education than the patients. So
yeah, we controlled for that in the analyses, yeah.
Okay. And then the second question is, I'm just wondering if you can clarify something for me. I'm not sure if I think I lost something in all the details. So when you looked at the, I think it was post-CBT, and you had the four principal components, and the second principal component.
The longitudinal principal components.
So I'm forgetting that you were saying there was increased connectivity?
Right, following CBT, the connectivity increased.
And that was within that frontal network or between the frontal and the amygdala?
And the amygdala, between the amygdala and the fronto-parietal network.
But then in the initial finding, I thought you said that the patient groups had, that the depression symptoms were associated with greater connectivity between amygdala and dorsal?
So the depression symptoms were associated with lower connectivity of amygdala to DLPFC, but it was the anxiety symptoms that were correlated with higher ventromedial prefrontal cortex.
Makes sense. Yeah. All right, thank you.
Hi, Yvette, thanks for the talk. Couple questions. First of all, when looking at PTSD, you were sort of focusing on the hyperarousal component of PTSD, right? Because the mask anxiety symptoms kind of pulls out that dimension. Would you have the opportunity, or do you think you have enough data to look at other aspects of PTSD that might be different? For example, re-experiencing symptoms, which are, not necessarily orthogonal, but also not necessarily highly correlated with hyperarousal. You might get a different picture. And then I guess
we have that data, so yeah, we could do that.
So it might be worth looking at. And then the second question, you kind of alluded to it, as to whether or not you think PTSD in women exposed to intimate partner violence would show the same sort of patterns of brain connectivity as other types of PTSD. And it's a question we always get asked a lot. Is all PTSD the same once you get there, or is it different neurobiologically? I know you've only got the one group in your study, but any references looking outside of your study to other studies to see if the findings are similar or different?
I don't know of either resting state or emotional task performance across PTSD groups. I mean, I should ask you. Are you aware of any? Because that would be important to know about the syndrome of PTSD. Is it really the same across these different groups, or is it more similar or more different across the different groups? And then I think you also get into the area of trauma exposure and getting the head trauma involved and what that does or doesn't do to change the syndrome.
So I'll ask two questions. So if I were to think of this in a simple way, which is the only way I can think of things most of the time, CBT is working by helping our frontal lobes take more control over our limbic system.
Yep.
Okay. So a poor man's approach to this was done in the 80s with FDG PET by Jeff Schwartz, a former UCSD trainee, and Lou Baxter. And what they found in OCD was that CBT's effects correlated with actually reduced connectivity, if you will, correlated metabolic activation between frontal lobes and basal ganglia structures. So what they call sort of the paradigm was brain lock, that there was a locked connection between frontal and basal ganglia circuitry, and that via CBT you could unlock that connection, so you were less controlled by your subcortical mechanisms. So the second question is, have you been able to look at connectivity between frontal regions and striatal regions and see if that changes in this form of CBT.
Well, so I'll go back to the first point. We rejected that approach of starting with our favorite regions. We could go back now and say like, oh, we let the data take control and it drove us towards amygdala frontal analyses. But if we decide that we just want to look at this less significant connection, do we see a change here? I mean, sure, we could do that.
Only because it's a change that was also shown to happen in CBT and anxiety disorder.
Yeah. Mm-hmm.
And so then my second simple question is, if that is the model that we're essentially CBT is helping our thinking brain take control over our feeling brain,
Mm-hmm.
if you will, is there a way to show that directional causality as opposed to the opposite in this data? I mean, is in connectivity
You mean
data?
like the limbic getting calmer and just letting the prefrontal do its thing?
Stop
versus,
thinking as much or whatever it is. Yeah.
versus like strengthening the prefrontal,
Right.
so the direction that's doing. I don't know of a way to get the direction. So all these methods are sort of agnostic as far as what the direction would be. It just looks at the outcome. Yeah.
Right. Yeah.
Mm-hmm.
You know, in essence, it's, I mean, I hate to dumb it down to that level, but in essence, I think that's one way to interpret the data here. Yes, exactly right. If it's dry, it's wet, make it wet. If it's wet, make it dry. If all else fails, use steroids. That's right. That's the thing.
But you know, for CBT, that is, I mean, think about what you do with CBT. You tell them, think about it. Use your brain. Don't think that you're a schmuck. You know,
Right.
think.
No, intuitively, that's the direction that makes sense from a clinical standpoint. And I was just wondering if the brain imaging can tell us that they were thinking about it right.
Mm-hmm. I don't know. Mm-hmm. Mm-hmm. So do it every week. Mm-hmm. Mm-hmm. Oh God. Mm-hmm.
So you can see the individual parts of the therapeutic process act in action in the brain as it was happening.
Mm-hmm. Mm-hmm.
You have a question back here?
I think like a way of looking, like matching our data to this thinking brain to like the emotional brain is a initial hyperconnect, isolated ventral attention system to a more diffuse is a and as the CBT takes effect,
I think the mic is dead. I'm not hearing you.
So I think what a parallel would be from your point of like the thinking brain to the emotional brain and how the effects of therapy work would be given with your data. Initially, like the network is the ventral tension is very fixed to itself, right? It's very isolated and hyper connected to itself, not other systems, right?
Mm-hmm.
And as therapy works, or there's after therapy, it's more. It completely changes. It's not connected to itself. It's not connected to other things. So you're allowed to ruminate less, and that's kind of like the fog, that blue that you see. The depression gets lifted, and you're allowed to see other things. other than that. So that's like a way of looking at it in both ways.
So rumination is sort of the stuck in the set kind of concept. So it's asking changes within symptom domains in the MADRS.
Oh, we didn't look at that.
Other questions? Well, I want to thank you very much for this and the discussion that followed. I think framing it in a way that helps us understand or at least have a model for what's happening clinically as our trainees are learning CBT and applying it with their patients. And very, very helpful. Also, we have a tradition at UCSD for our Grand Round speakers. In addition to our great thanks, we also provide you with a UC San Diego School of Medicine Department of Psychiatry hat, which you have to actually model for us since you're on the camera, and to keep to wear it in Philadelphia whenever the sun comes out and whenever it does, and also want to wish you best of luck in the Super Bowl 2 weeks from now. Thank you very much.
I don't think that's going to help.
Okay, good. Thank you so much.